Hey, this is Miss V again. Hopefully you did your concept maps and didn't have too much difficulty with those. So our last little section, we're going to look at, we're still talking about acid-base balance, and we're going to talk about how respiratory and urinary, the renal mechanisms can compensate one another. So there's a time course of hydrogen ion regulation. First line of defense against pH shift is going to be our chemical buffer system. Remember, we have three of them. The bicarbonate buffer system is going to be number one in extracellular space. We have the phosphate buffer system, which is in urine and intracellular. And then the number one in intracellular fluid compartments is going to be that protein buffer system. The second line of defense in pH shift are going to be what are called physiological buffers, not chemical buffers. We looked at the respiratory mechanism. We know that wherever our carbon dioxide goes, that's where the acid goes. So if we exhale, we get rid of our acid. If we underbreathe, we're holding on to our hydrogen ions and acid. And then through the renal mechanism, we know that we can get rid of our hydrogen ions through urination. This is going to take some time. That is going to be the slowest. Buffers are the fastest. Just kind of reminding you, our normal set pH is going to be 7.4, and anywhere in this range, 7.35, 7.45 is okay. Like I said, normally our chemical and physiological buffers do a really good job of keeping us in this range, but there are abnormal conditions that can disturb our acid-base balance. What we're going to see is if a patient has respiratory issues, that the renal system can compensate for that respiratory system's lack. If someone has kidney disease, then the respiratory system can compensate for that system. So they kind of really do work together. All right, so just acidosis. How can someone get acidosis? Anything that causes an accumulation of acids or a loss of bases is going to increase the hydrogen ion concentration. The pH is going to drop, and then we get acidosis. So there's two types, and like I said, this is kind of where we're headed, and we'll do some problems to kind of help you get a grip on this. So you can either have respiratory acidosis or you can have metabolic acidosis. And so respiratory acidosis, this is telling you it has something to do with breathing. We can get an accumulation of abnormally high carbon dioxide levels, so hypercapnia. And so this occurs when somebody is under breathing. So decreased rate and depth of breathing or hypoventilation. That is going to cause an accumulation of carbon dioxide, which is going to lead to respiratory acidosis. You get this under breathing when there is obstruction of our air passageways. We talked about COPD. So you can have obstructive pulmonary disorder, or you can have a restrictive pulmonary disorder. If someone has pneumonia, they're going to have a decreased gas exchange. So if there's fluid in air sacs or any pulmonary edema like in congestive heart failure. But any of those things, this sort of under breathing, is going to lead to an accumulation of carbon dioxide, and so that's going to lead to respiratory acidosis. Metabolic acidosis, now when we use this term metabolic, that is due to any other acid besides carbonic acid. So anything, if it's not respiratory, then we call it metabolic. And so things that can cause that, kidney failure to excrete excess acids, that's going to cause an accumulation of non-respiratory acids. That's going to lead to metabolic acidosis. We can have other issues. We can have excessive production of acidic ketones, as in diabetes mellitus. That's going to cause that accumulation of those ketone bodies. We get metabolic acidosis. If you pop down here, we could also lose our bases and drop our pH. So if someone has prolonged diarrhea with a loss of alkaline intestinal secretions. Spoiler for Unit 4, you have one region of your body that is alkaline, and that is that first proximal part of the small intestine right after the stomach. So if someone really has diarrhea for a long time, they are cleaning themselves out, or prolonged vomiting, like they vomited up their stomach and now they are sucking out stuff from their small intestine. We lose our bases. That too can lead to metabolic acidosis. So alkalosis is going to be the other way. And to be honest, this is not as common as acidosis because, like I said, we are always making acid. We're always trying to get rid of our acids. But you can get to alkalosis if you lose your acids or if you accumulate bases. Either one of those is going to increase the concentration of hydrogen ions, which is going to raise the pH, which is going to lead to alkalosis. So there's two types of alkalosis. There can be respiratory alkalosis or metabolic alkalosis. So when we talk about respiratory alkalosis, like I said, we're just talking about breathing. And so in this case, we are blowing off more carbon dioxide than we are making. So this is going to be over breathing, so hyperventilation. So we're going to have abnormally low carbon dioxide levels in the blood, so hypocapnia. So hyperventilation can be triggered by pain, stress, fever, poisoning, high altitude. So hyperventilating, we are excessively losing our carbon dioxide. So we're decreasing the concentration of carbonic acid, decreasing concentration of hydrogen ions, and that's how you get to respiratory alkalosis. So high pH. Metabolic alkalosis can occur, still not as common as acidosis, if you lose your hydrogen ion. So that's up here. If someone has gastric drainage, so they have to have their stomach pumped, or excessive vomiting because the pH of the stomach is about pH 2. But if you have an excess loss of acids, that you get a net increase in alkaline substances, and that can lead to metabolic alkalosis. Another way is just an overdose of antacids. Antacids are basic. So someone could just take those, and there's also other drugs that can lead to metabolic alkalosis. So compensation. So compensation of renal and respiratory in acidosis. So when you have a patient with respiratory disease, the kidneys, especially respiratory disease that is slow to develop and chronic, meaning not an acute sudden thing, the kidneys are going to compensate that increase in acid. And so kind of following this train over here, so what the kidneys are going to do is they are going to increase their reabsorption of bicarbonate, and they are going to actively secrete hydrogen ions into the urine. So what you're going to see in the case of renal compensation is that there's going to be an elevated level of bicarbonate, because we know when we have high bicarbonate, pH goes up. And then you're going to see a lower pH in the urine. So renal can compensate for respiratory. So compensation of renal and respiratory and acidosis in patients with renal disease, what you may find is that they are going to have an increased rate and depth of breathing. So if you have dialysis patients, when they get up from the waiting room to come walk in, you're going to hear them breathing more deeply and more rapidly, because that is an easy way for the body to rid itself of acid. So by increasing the rate and depth of respiration, we can lower blood CO2, which lowers carbonic acid, which is going to help raise the pH. So in patients with kidney disease, the body will compensate through the respiratory system, and that can be actually pretty quickly done. So everything I just said, for alkalosis, it's going to be the opposite. If a patient has respiratory alkalosis, and this would have to be over time, because it takes a while for the kidneys to make urine, the kidneys can compensate. Then there would be low levels of bicarbonate in the blood, and the urine would be more basic, because the kidneys would then hold on to hydrogen ions. So now we're going down this side. So the kidneys have the ability to secrete bicarbonate. They can hold on to hydrogen ions. That's going to lower the pH and restore homeostasis in the case of alkalosis. In the case of respiratory compensation, once again, so now if we have alkalosis occurring, that's going to reduce the rate and depth of breathing. So we can hold on to our CO2. That holds on to our carbonic acid. That's going to lower the pH, and so respiratory can compensate for that alkalosis. So we can try to accumulate our carbon dioxide. Okay, and like I said, pretty much if we have a shift in pH to the extremes, either acidosis or alkalosis, pretty much neuromuscular functioning, everything's going to be affected as well, because just enzymes aren't working, hormones aren't working, and electrolyte imbalances are also going to occur. I know I don't expect you to know all those, just showing them to you. Okay, so clinically, these values are always going to be measured. And so acid-base imbalances, they're going to be diagnosed and measured by what are called ABGs, arterial blood gases. And so when blood is tested, they're going to get the pH, the partial pressure of carbon dioxide, the pressure of oxygen levels, bicarbonate, and then saturation of oxygen as well. And so these are common things that are done clinically. So I'm going to give you some case studies to work on, but I would like to do one together so you can kind of see how to do them. And so what we're trying to determine right now is we are going to see if there's a pH imbalance. We'll want to see if it is either respiratory or metabolic. And then we're also going to ask ourselves if there is compensation by the other system. So let's read together. A patient with a history of chronic obstructive pulmonary disease, so this is an airway disease, was rushed to the emergency room with increasing shortness of breath. Pyrexia, so fever, a productive cough with a yellow-green sputum. So he's coughing things up. Measurement of arterial blood gases, so ABG, shows a pH of 7.3. And so I've given you normal values down here. So 7.3, is that high or low? Yep, so we know pH is low. It's below 7.35, so it's too low. Partial pressure or arterial pressure of carbon dioxide is 68 millimeters of mercury. So let's just pop down here. Oh, our normal values are 35 to 45. So what does this tell you about CO2? Okay, so CO2 is high. Let's look at our next value. Bicarbonate is 28 millimoles per liter. And so pop down here. Oh, bicarbonate is high. All right. And partial pressure of oxygen is 60 millimeters of mercury. So let's go down here. Oh, okay, so it's low. We have low oxygen. Okay, so hopefully you got that, and we just got that from those values and compared them. First thing we want to know is, does this patient have acidosis or alkalosis? So pH is low. Oops. Okay, so like I said, that's always the first question you want to ask, acidosis or alkalosis. The next question we want to ask ourselves, is it respiratory or metabolic? Okay, now you can probably read what's happening with the patient, and we already said they have a history of chronic obstructive pulmonary disease. But let's pop over here, if you will, to our respiratory is opposite, metabolic is equal. And so we know that pH is low, and so pH is low, and if it was a respiratory issue, then carbon dioxide would be high, and that's exactly what we see. So that confirms our thought that this is respiratory acidosis. Pop down here for me. Let's say we weren't too sure, okay? Maybe I didn't give you as many details as far as what's happening with the patient. If it's a metabolic issue and pH is low, so down here, then that would mean if it was a metabolic issue that bicarbonate would also be low, and that is not what we're seeing. So we have confirmation that this patient has respiratory acidosis. Okay. So the next question you want to ask yourself, is there renal compensation? Since we know we have a respiratory issue, the only other system that can compensate would be renal. And so now we're asking, is there compensation? So how would we know that? Is that when we talk about renal compensation, that's a metabolic thing. We're not talking about respiratory gases, so we're not talking about CO2. So now we're looking at this. If the bicarbonate values are different or out of the normal range, that's how we know that there's compensation. And that's exactly what we see, that the bicarbonate in this patient's arterial blood gases is high. This patient has had a long history of respiratory disease. So that means the kidneys have had time to help compensate this problem. Probably what happened to this patient is they got an infection on top of their COPD. So the infection was acute, so they are in distress, but they are having renal compensation. The kidneys have been trying to help out with the COPD by holding on to bicarbonate. Oops, oops, oops. So that's how we know if there was no compensation, this value would be normal. Okay, so yes, there's renal compensation. Okay, so that was the answer to this problem, respiratory acidosis with renal compensation. Okay, so I have some case studies for you, and I'd like you to give those a try on your own, and I believe I'm going to record a video that kind of goes over the answer to those, and I will post those answers as well. But do yourself a favor and actually try to think through it on your own. Talk to you soon.